Well, welcome everyone, wherever you are and whatever time zone you're in, to this first episode of a continuing series of International Society of Nephrology and Kidney Disease Improving Global Outcomes webinar-based series on complement and glomerulonephritis. Today's session, the first of 4 planned sessions, will have a special focus on C3 glomerulopathy. There are 2 goals and objectives of this session: to better understand the definition, clinical features, pathology, progression, and pathogenesis of C3 glomerulopathy, and to better understand the current approach and guidelines for the evaluation and management of C3 glomerulopathy. I'm Dr. Glassick. I will act as moderator for this session. I'm from the David Geffen School of Medicine at UCLA, and we're extremely fortunate to have 2 internationally recognized authorities in this field who have had broad experience in many aspects of the disease and diseases we will be discussing. Dr. David Kavanagh is a professor of complement therapeutics at the National Renal Complement Therapeutics Center in Newcastle. He is also an honorary consultant nephrologist at Freeman Hospital in the Newcastle upon Tyne Hospital system in Newcastle, United Kingdom. He will kick off the session with his talk, and immediately after that, Carla Nestor, the Jean Robillard Chair of Pediatric Nephrology and Division Director of Pediatric Nephrology, Dialysis and Transplantation at the Stead Family Children's Hospital at the University of Iowa, and also Associate Director of the Molecular Otolaryngology and Renal Research Laboratory, Morrill, which many of you are already familiar with. The speakers will be given 20 to 25 minutes to develop their subject material, following which we will have a question and answer session. Please post the questions that you would like to ask on the question box, and I will do my best to try to synthesize these questions so as to focus the questions for the speakers on topics of general interest. We will begin the talk with a presentation from Dr. Kavanagh.
Thanks very much. It's a pleasure to speak today. I'll put up my disclosures to start with there. And today we're going to discuss one of the prototypical renal disorders of complement overactivation, C3 glomerulopathy. With the 2nd generation of complement inhibitors in late-stage clinical trials, this is a very exciting time for the field. And I will be the warm-up act for the main feature, Carla. I'll discuss the kind of clinical features of disease, pathology, disease progression, and the underlying pathogenesis. And then Carla will tell you about the current management strategies and hopefully about future complement inhibitors in disease. C3G is not a newly recognized disease. The term was adopted in about 2013 to define a group of rare kidney diseases in which dysregulation of the complement cascade drives the pathology. Dense deposit disease has been known for decades and was known as MPGN type 2, whereas C3 glomerulonephritis was historically classified as either atypical MPGN type 1 or 3. But really, this new classification of C3 glomerulopathy allows stratification of complement investigations and patients into clinical trials. The alternative pathway of complement evolved to kill bacteria, and because of that, it is a positive amplification loop. The alternative pathway is constitutively active, but can be activated by the classical pathway via antibodies or by the lectin pathway via bacterial sugars. C3b binds to factor B, which is cleaved by factor D to give C3bb, which cleaves more C3b, resulting in this amplification loop. Unchecked, this leads to the formation of the anaphylatoxin C3A and C5A, then opsin in C3b, and the membrane attack complex. Now, regardless of the activation pathway responsible, about 80 to 90% of terminal pathway activity goes through the alternative pathway. Because of this, we have a series of complement regulatory proteins, including factor H and factor I. These are the main proteins involved in C3G. Factor H is the cofactor for the enzyme factor I, which cleaves C3b and prevents further amplification. In the normal setting, the alternative pathway convertase C3b-BB, once formed, is quickly degraded and has a half-life of about 90 seconds. And it's when that's prolonged that you get C3 glomerulopathy. C3G is pretty rare, 1 per million population per year, and it can either be genetic, rarely, or acquired, and you need a biopsy to make the diagnosis. The clinical presentations are varied. It may be asymptomatic. You might present with hematuria microscopically, or proteinuria, or you might present with the classic signs of a glomerulonephritis. One of the key features of it clearly is a low C3 level, and that would be low in the majority of cases, and that should lead to the consideration of C3G as a diagnosis. In C3G, it usually follows a chronic course with persistent alternative pathway activation. Up to about 80% of children will develop end-stage renal failure within about 10 years of diagnosis. In adults, this is slightly less, about 30 to 50%. And there will be some cases that present with a crescentic or a rapidly progressive glomerulonephritis. Post-transplantation, it can come back. If you biopsy people after transplantation, most will have C3G recurrence documented immediately, but about 50% of cases will lose the graft as a consequence of this within about 10 years. There are extrarenal manifestations of C3G, and those with C3 nephritic factors and C3 glomerulonephritis, facial lipodystrophy can be seen. Factor D is expressed in adipose tissue and is required for the formation of the C3 convertase. And it has been suggested that loss of fat may be because of C3 neph-induced lysis of the adipocytes expressing factor D. Drusen can also be seen in patients with C3G, and drusen is also one of the hallmarks of age-related macular degeneration. And now there's overwhelming evidence in the literature linking factor H, factor I, and C3 elements of the alternative pathway to AMD pathogenesis. And indeed, therapeutics targeting the complement system are being used in that. And some of the ones Carla will tell you about later on are also being used in AMD. But the extra manifestations of C3G are undoubtedly complement driven. Now, immunostaining defines C3 glomerulopathy, sole or at least dominant glomerular C3 deposition more than 2 times more than any other immunoreactant is required for the diagnosis. The deposits can be semilinear to granular, but there is overlap of C3G in immune complex MPGN. The new classification of C3G includes cases of MPGN that were previously classified as type 1, 2, or 3. And furthermore, the definition of C3G identifies cases without MPGN in which there may well be complement activation, which might otherwise have gone unnoticed. Additionally, in this immune complex arm, there will be cases of the drivers of complement activation you see in C3G. So there is overlap, and you will find C3 nephs and mutations in this immune complex group. Electron microscopy is necessary to distinguish the 2 major subtypes, dense deposit disease and C3 glomerulonephritis. In dense deposit disease, you have highly electron dense deposits that thicken and transform the lamina densa of the glomerular basement membrane, while in C3 glomerulonephritis, the deposits tend to be less dense and more amorphous and ill-defined. Findings in light microscopy are fairly diverse. You can go from no hypercellularity to really a crescentic type picture. And as Carla will describe later, some of these pathological findings will guide what we do when it comes to treating the disease. I've said there's an overlap between C3G and immune complex MPGN, and there's an additional complication in that, and in that it depends how you look for this on your renal biopsy, whether you use immunofluorescence or immunoperoxidase. And clearly, from what's been written in the literature, immunofluorescence is by far the most sensitive and reliable technique to look at this. Additionally, pronase digestion can unmask immunoglobulins that wouldn't normally be seen. We see this predominantly when you have a paraprotein that you might not detect, and it is useful, and it will alter what you do if you find immunoglobulins unmasked, certainly in the case of a paraprotein. Additionally, you can look for C4D, as if there's no C4D there, it helps to exclude an immune complex. One of the problems with a biopsy diagnosis, that at least initially, you get co-deposition of IgG and C3 in patients with post-infectious glomerulonephritis. However, later on, you can get a C3 dominant type disease, and that might be seen late in a post-infectious glomerulonephritis. Therefore, pathologically, you can't really distinguish between these two entities, and the definition is largely clinical. If you have a patient where with post-infectious glomerulonephritis, what will happen is within about 3 months, they'll recover their kidney function, the hematuria will get better, the proteinuria will disappear, and the hypocomplementemia will resolve. And if it's not doing that, then the patient needs a biopsy, and you could well see C3 glomerulopathy in that sort of situation. So for post-infectious glomerulonephritis against C3G, pathologically, it's very difficult. You can't differentiate pathologically, and you need some clinical knowledge to make a complete diagnosis on that. Predictors of disease, well, perhaps unsurprisingly, evidence of chronicity, either pathologically in the form of tubular atrophy, interstitial fibrosis, or the presenting EGFRs, are poor prognostic markers. In some studies, certainly in children, crescentic disease is also associated with renal failure. Now, unlike atypical HUS, which is the other prototypical disorder of complement dysregulation in the kidney, C3G is a predominantly acquired disease. In C3G, you have autoantibodies against a variety of different complexes and proteins. And clearly the commonest and the one best known is the C3 nephritic factor. This stabilizes the C3 convertase, that C3BBB, and increases its half-life, and that drives the complement turnover. Some of these C3 neph may also result in a C5 neph, which results in terminal pathway activation, and they're relatively common too. But the other ones, antibodies against components such as factor B, C3b, and against your factor H regulator, are less common, about 10%. But interestingly, the antibodies you see against factor H, which you also see in atypical HUS, bind to the N-terminus of the protein, not the C-terminus. Largely in C3G, the driver of pathology is autoantibodies. In studies, up to 25% of patients will carry a rare genetic variant, and these tend to be in the C3 convertase gene C3 or factor B, and also in the regulatory proteins factor H and factor I. Again, as I've kind of alluded to with the previous discussion about epitope mapping and antibodies in HUS and C3G, there are hotspots for genetic variants in C3G, and that's predominantly in the N-terminal region of factor H. And more recently, we've identified duplications and rearrangements, which we'll come on to. It should be remembered that not all of the variants described will be functionally significant, and actually it's probably a relatively low percentage where you can absolutely be clear that they drive disease. Ultimately, you may require functional analysis of these variants as seen here to be clear on that. Now, I have said that there are hotspots. This is C3b in cyan, and then you have factor H binding in dark grey and factor I in blue there. The mutations in HUS are on the C-terminal end. This groove you see here is where sialic acid interacts with factor H and C3b on the cell surface, and the mutations in red are HUS associated ones and the C-terminus. And now you will see that the mutations in C3G are at the N-terminal end, and that results in fluid phase dysregulation rather than the cell surface dysregulation you see in atypical HUS. Now, the classical model of C3G is a factor H deficient mouse. It develops a C3G-like disease. And when you cross this with a C5 knockout, the C3G is less pronounced. You have reduced glomerular hypercellularity, reduced mortality in the mice, and reduced creatinine levels. There are currently 2 agents that would target that. Avacopan and eculizumab would mimic this sort of situation. Interestingly, when the factor H deficient mouse is crossed with the factor I deficient mouse, there's no evidence of C3 glomerulonephritis on light microscopy, highlighting the inflammatory potential of IC3b. IC3b is only generated when factor I is present. However, when you take complement blockade upstream at the level of factor B, there is no evidence of disease. And there are now several agents that are currently targeting upstream alternative pathway positive amplification loop, and Carla will discuss these later. I touched briefly on factor H rearrangements. The factor H gene sits in a region called the RCA cluster, and that RCA cluster arose by a series of genomic duplications, and this results in instability in this area. When you get a double-strand break in the genome, what you would ideally like to happen is homologous recombination to repair the genome. And I'll just show you that more diagrammatically. This is the RCA cluster, and this is your factor H gene here and your other factor H related genes. And you see areas of high homology in these colored boxes. Now, when you have a double-strand break, what you would ideally like to see is your other allele acting as a template to repair the broken strand. Now, because of the homology in this area, what can happen is that when you get this break, the template is misaligned and you can get hybrid genes. And we're increasingly finding in C3G that you can get these hybrid genes. All these hybrid genes in C3G tend to have this dimerization domain. And this is a very interesting domain in that it's recently been described to allow these proteins to dimerize. You can get various different dimerization between these 3 different proteins. And when you, what you would normally get for regulation is factor H downregulating C3 beta IC3b with its cofactor. However, these hybrid genes have these additional dimerization domains that allow multiple polymers of these related genes to essentially bind and outcompete factor H in the glomerular environment. And we're increasingly finding that these are driving disease. Now, the most common and the best well characterized of this is the CFHR5 nephropathy, which is endemic to Cyprus. This creates a fusion protein in which CFHR5 has an extra dimerization domain and competes with factor H. It's variably penetrant. Most people will just have microscopic hematuria, but in about 40% proteinuria will develop. And in that group, that's a portent of chronic renal failure in nearly all patients. Interestingly, there is a male-female split. 80% of men, but only 50% of women will will progress to end-stage renal failure over their lifetime. Thus, in summary, C3G is rare. It's clearly driven by the complement system, as its name would suggest. It's predominantly acquired. It's predominantly driven by autoantibodies, and genetic variation is seen, but less common than, say, typical HUS. We've seen from the mouse models, they are very good models of disease, and they would suggest that blockade at the level of the alternative pathway would be where you would want to target disease. And genetic analysis is very helpful, but it doesn't currently allow you to predict outcome or tailor management to the same degree as an HUS, though in some cases of MPGN, you can identify non-complement causes such as DGK epsilon. And with that, I shall hand over to Carla and thank my team in Newcastle.
Thank you very much for the excellent presentation, and thank you to everyone who is joining us today. I'm going to be now handling the clinical approach for this group of diseases, and I'm going to be focusing quite a bit on what the KDIGO has to offer in terms of suggestions for how to address C3G. I have a rather large list of disclosures, primarily to give you because I do work in a complement functional lab, number one. Number two, I am working quite a bit in the clinical trials arena. So those are important disclosures for you. I have three objectives for you. First, I'm going to review the terminology because I think from a clinician standpoint, the terminology can be confusing, but it doesn't need to be if we just remember what the sequence of things is. I'm also going to be considering the recommendations for evaluating the complement system, which is new to the KDIGO this year. And then also I'm going to review the expert opinion guidelines. You'll find out, and you'll hear us say again and again in this setting, very little by way of trial data for us to rely on yet, but there's lots of exciting movement in that direction. So next year, this discussion will be very different. So first of all, terminology, C3 glomerulopathy or C3G, it's the disease process. So that's clear to, I think, most of us. What is might not be quite as clear as this concept of C3 dominant glomerulonephritis is actually the pathologic description. This is what your pathologist will read on the biopsy, and this is what should show up on your biopsy report. The problem with that particular description, it's not a problem for the pathologist, it's a problem for us as clinicians because it's the same description that will be used in C3G or the C3 dominant variety of post-infectious GN. And then perhaps a little unfortunate, if you get rid of the dominant terminology, then C3 glomerulonephritis is that it's one of the types of C3G. So those are the fluffier deposits that you were introduced to, as opposed to dense deposit disease, which has those very dense intramembranous deposits. So the confusion can happen when we're speaking about C3 dominant glomerulonephritis, the pathologic description, and C3 glomerulonephritis, one of the varieties of C3G. Then, new to this KDIGO this year also is the concept of bringing to a much higher level this concept of immune complex glomerulonephritis or ICGN. This is now the preferred disease terminology for those idiopathic membranoproliferative glomerulonephritides. As opposed to, you may recall a previous chapter, even in your own practices, we've referred to a disease process known as MPGN. The KDIGO this year is discouraging that and moving it back to what it really has been all along. It's a pathologic pattern. The MPGN pattern can be seen in IgA, it can be seen in lupus nephritis, it can be seen in C3G, etc. When we're really talking about the idiopathic form, we should use the immune complex GN terminology. So what are some of the diagnostic challenges the clinicians may face? Well, first of all, let's start with, this is the diagnostic criteria. It has to be 2 orders of magnitude greater than any other immunoreactant. This is what Dr. Kavanaugh presented to you already. This was the consensus decision back in 2013, how we would call this disease. The problem really comes if you don't pay strict attention to this idea of 2+ or 2 greater, you can pick up some FSGS patients. You may be aware, and this is my opportunity to mention to you, I've not done an extensive introduction of the references here, but instead just pulled up representative ones. You can find data to support that FSGS patients can have C3 deposition. It's often associated with IgM, of course, but they can have C3 deposition. And if you're not careful to pay attention to this, you can rope in some FSGS patients to this diagnosis. Similarly, in my experience, end-stage kidney disease biopsies often have trace to 1+ C3 deposition. So keep that in mind when you're trying to label whether someone actually has C3G or not. Again, it does not have to be isolated C3. And in fact, one of the very nice series reported out by the Columbia group, up to 59% of those patients that were clearly C3G by phenotype, by biomarker, et cetera, they actually had IgM deposition. So keep in mind, and most of you are aware of that because that definition has changed for a while now. And then finally, as is already mentioned, the light microscopy pattern is quite variable. We no longer have to call dense deposit disease patients MPGN2. They may be dense deposit disease patients without, believe it or not, the MPGN pattern. So that's why it's important to remember that there's quite a bit more flexibility than you might have thought about previously. So a new concept, or a relatively new concept, is this idea of the biopsy may not be static, and that was already introduced to you. There will be patients that you thought were immune complex GN, and you thought that they were post-infectious because they have a classic post-infectious biopsy, but then they still have glomerulonephritis 2 years later. You rebiopsy them and they are in fact C3 dominant this time, or even C3 isolated. And that was actually also found in that Columbia population. About 8% of those patients transitioned from immune complex GN to C3G. Since we're all in the COVID area, I will give you personal experience. I have had 2 C3G patients, subsequent biopsies after a COVID infection and worsening of urine protein. Now they have immune complex GN when I biopsy them. The point of presenting that is, this is now a post-infectious biopsy in the backdrop of a patient who truly has C3G. So again, keep in mind, there is a lot more flux between these than we originally may have thought. As has already been introduced to you, ruling out infection is incredibly important because for treatment and outcome reasons, but because particularly the outcome reason. From the consensus, renal biopsy that meets diagnostic criteria, so that's 2 orders of magnitude, but the biopsy really needs to have been 12 weeks after the purported infection. And that was, again, expert opinion, but that group believed that if you collected the biopsy 12 weeks after the infection and it is still meeting criteria, that is one of the best ways to rule it out. You've already been given a hint about the clinical parameters that will change. This is one thing I wanted to remind people. C3G biopsy can look exactly like the post-infectious biopsy. And I often hear people say, but this one has humps. Again, I refer you to a number of publications. We can go back to the Columbia publication. In really good DDD patients, they can have subepithelial humps. So subepithelial humps does not equal post-infectious GN. Why do we stress working this out, separating these 2 diseases? Because, of course, post-infectious GN, which occurs more commonly in children, yes, but does occur in adults, is a transient complement activation process. It should not give you chronic glomerulonephritis. Yes, we can agree that C3G patients may present after an infection, but they should still continue to have glomerulonephritis well past the 12-week time frame. And then, of course, one of the newer things addressed in the KDIGO this year was this idea of ruling out paraprotein-related disease. I was discussing with Dr. Glassuk before we started this session. This concept can take up an entire lecture, so we will not spend a lot of time on this, but I just wanted to present with you the practice point that KDIGO brought forward this year was this idea that if your patient presents with C3G for the first time at or older than the age of 50, it was strongly encouraged that you look for monoclonal proteins. And again, the short answer to this is that some of these monoclonal proteins can dysregulate the complement system. We've known, for instance, since 1992, I think I gave you the reference for that one, that a lambda monoclonal can actually act as a factor H, more like an auto, it's not an antibody, but an auto inhibitor, if you will. So the point is, C3G patient that presents for the first time at the age of 50 or older, consider whether they might have a monoclonal. Why do we want you to do that? Well, it's because if you go after the clone, it does appear that these, again, just one study I'm presenting here of 50 patients, it does appear that they are going to have improved renal survival. So it's possible that going after the clone is your treatment approach, rather than, strictly speaking, going after the targeted therapeutics that we're going to be thinking about moving forward in the other C3G patients. So how about evaluating the patients further than this monoclonal idea? Well, of course, this doesn't surprise you in this state, in this KDIGO, as it was in the last one. If you have an immune complex GN patient, it's most likely going to be triggered by some sort of intercurrent illness, whether that's hepatitis, et cetera. There are other things. You're going to go looking for underlying disease. You're not going to jump immediately to this thinking, thinking that it's just idiopathic or that it might be complement mediated. And then, of course, again, even in the immune complex patient who is younger than 50, if you don't find anything, consider the possibility of the monoclone being present. I really won't spend a lot of time on that because we're really wanting to be focusing a bit more on complement. So I'm going to bring forward this practice point, which applies both to immune complex GN and C3G, if you've ruled out the paraprotein, if you've ruled out infection, that if you really are finding no other cause of disease, really, this is the point, that you should be considering looking for complement dysregulation or drivers of disease. That might be a little bit more obvious for you in C3G, but part of the reason why it's also being put forward for the immune complex GN group now, this expert panel believed it was important because of what's been reported to you about this transition between the two diseases, because we're based simply on what's being deposited on the biopsy, right? So there can be some confusion there. But then there's also a reasonable collection of data that would suggest that idiopathic immune complex GN patients are just as likely as C3G patients to have underlying complement dysregulation. And you can pull up a number of manuscripts that actually will support that idea. So what I want to do is talk a little bit more about what's this idea of working up the complement system. This is the cartoon that I will often use. And the reason I do is because it happens to match what we do in our laboratory setting in terms of looking for those complement parameters. And it does, to a degree, match what KDIGO has put forth as far as how you should think about evaluating these patients. So again, the complement system the alternative pathway should move from C3 down to the membrane attack complex, or C5b through 9, and you should see the consumption of products or the production of breakdown products, I'll put it that way. So you've already heard that approximately 25% of C3G patients, for instance, carry these variants in complement genes, but up to 80% actually carry an acquired driver that we call a nephritic factor. Already has been mentioned what some of the other autoantibodies are that are not nephritic factors. What I really wanted to bring up is that these genetic abnormalities are often a sort of gain of function, meaning they cause the complement system to be hyperactive, and that's what was already presented to you. But also the nephritic factors do the same thing. So the nephritic factors bind to and stabilize these critical enzymes of the alternative pathway, which, by the way, I don't know if Dr. Kavanaugh mentioned, but I should mention that the alternative pathway, by the way, is the amplification loop for the classical and the lectin pathway. Again, that's why the alternative pathway becomes such an attractive target when we're moving forward to some of these newer therapeutics. But so this is what it looks like in terms of the patient's risk. If you look at this figure and then move to the table that KDIGO brought to you, and again, I think in these slides and in a number of places, you'll see the website where you can pull up these guidelines, but the assays where you can evaluate patients are broken down into several categories. And I've provided this particular figure for you so that maybe you can compartmentalize them in your mind, but the functional assays deal with trying to decide which pathway is involved. Is it classical pathway or is it the alternative pathway? Those pathways will be abnormal, or the laboratory values will be abnormal, either when there is an inhibitor involved inhibiting the pathway, or if there is a particular deficiency of a necessary complement protein required to run the assay, if you will. So keep that in mind. Then there is, if you look at that figure that I gave you, or if you look at any complement figure, you'll see there's a number of complement proteins. We can measure their value, we can measure their level, and we can determine if they're being used up, either very low, for instance, or let's say that one of the alleles makes a null allele, if you will, and one of the alleles is a null allele. You don't make the same amount of protein. So you can discover that by looking for the complement proteins in this area, or with respect to the proteins. There are also measures of complement activation. These are some of my favorite, because if these are in excess of normal, they are clear indicators to you that complement breakdown is happening. So the system is not normally being regulated or is not normally functioning. And then, of course, you've been introduced to the antibodies. They tend to be drivers of disease, so not representation of the disease itself necessarily, but drivers of the disease. And then you've also been introduced to this concept of the genetic also drivers of disease. So this is what the full panel of complement evaluation would be for a patient who you suspected of having C3G, adding on, of course, this idea of working up the paraproteins. I will tell you very clearly, even at the time of producing this document, we knew that availability was going to be an important roadblock for people. And so this is probably for many of you a forward-thinking concept. You're going to be listening to us as we talk about this for years to come, about which one of these is actually the most important to go after. We completely recognize this, but it is very important for us to understand, and I would classify this as most of this as being the phenotype. It's very important for us to understand the phenotype of the C3G patients before we can figure out whether we're doing them any good or not moving forward. So what is the current treatment approach? Well, it's going to be very similar for immune complex GN and for C3G. And I will go through these pieces very quickly, only because you can definitely pull these up from the guidelines. So if you have less than 3.5 grams of protein, your kidney function is reasonably okay. You may be only thinking of supportive cares by, blood pressure control, ACE inhibition, ARB, et cetera. As opposed to when your patient begins developing nephrotic syndrome, you plus or minus normal kidney function here, you may be thinking now about a limited course of steroids. And the limited part is very important to me as a pediatrician and an internist, because we often obviously don't want our children being exposed to too much steroid. How about this concept of, if you now have abnormal kidney function and you are starting to see, of course, high-grade urine protein, maybe not at nephrotic syndrome yet. This is really with respect to immune complex GN, you're starting to talk about glucocorticoids and immune suppression. And I will be very clear with you, as I've already mentioned, there is not good trial data, I could probably say not trial data at all, that very much of this is still expert opinion, though I'll share just a few of the cohort studies that helped inform this. And then, of course, as happens in a lot of our GNs, if it's rapidly progressive, then very frequently corticosteroids and cyclophosphamide are being used. I wanted to bring this forward very quickly, that if the GFR is very low, perhaps supportive is the only thing we should be considering, just because of the sheer risk-benefit ratio. But keep that in mind as you're thinking about your individual patients. So that really sort of bridged both of them, but here's the specific recommendations for C3G. They're very similar, if you will. That one of the first things to keep in mind, it's not evidence-based, it is still very expert panel-based at this point. Part of the reason for that is that there's been quite a bit of variability across the cohorts, and I think I'm going to provide for you 4 or 5 of the cohort, very quick summaries of the cohorts, but and at the time that the consensus statement was being made, and even at the time that the 2021 KDIGO was being created, we still don't have the targeted therapeutics for our patient population. So that's a hope for the future. That's not anything that you all can use right now when you've got that C3G patient sitting in front of you to a degree. And we're going to talk about enrollment in clinical trials. First point, again, supportive cares for everyone, but also supportive cares for those patients. For the C3G group, we moved closer to, if they've got a urine protein that's actually getting closer to 500 to 1 gram, we need to probably consider moving past supportive cares. But and you can review this in great detail, but we've brought forward this concept of using prednisone and mycophenolate. This has been pretty well distributed, I'd say, across the globe because of the consensus conference, but then also now because of the new KDIGO has felt to bring that forward, and it still says that. And at the time of the evaluation, what the literature would support, that in a Spanish cohort and a Turkish cohort, we had 120 plus patients where we had response rates of 86 and 59%. So in a setting where you don't have the possibility, when you don't have the capability of using anything more targeted, then this sounds like pretty good results. Shortly after that, that particular presentation, what we discovered is that there were a couple of US cohorts that did not have quite the same response rate. And so I present that to you only because some of you may be noticing your response rates are lower. In my hands, it's about that 30% response rate, frankly. So keep in mind that it is expert opinion guided and not clinical trial guided. So we're having difficulty at this point telling you exactly which phenotype will respond. I did want to bring up some of the more recent data, though, that the Glossen cohort with the Spanish group has been very good about continuing to bring data forward to us. They present as 42 patients in a manuscript in 2020 that had 79% remission. So please, please, please remember, you absolutely may have some CellCept responders or mycophenolate responders. What about eculizumab? Well, the original guidelines didn't think that there was enough information. The KDIGO guidelines of 2021 felt that really eculizumab, so terminal complement blockade, was more likely to be an end or a last resort for you. And part of the reason for that is I'm going to give you one figure to share with that, because now we're getting to the point where we're starting to see whether, if your patient is not responding to the more routine cares, supportive, prednisone, mycophenolate, maybe rather than going after terminal complement blockade, you may want to consider clinical trial if it is available to you. And the main reason to do that is this concept of washout periods. And I couldn't resist telling you, I do appreciate how terminal complement blockade can help some patients. I 100% do, but I have discovered as a clinical trialist that if you're on the shorter acting terminal complement blockade, the washout is 90 days. If you are on the longer acting terminal complement blockade, the washout is 280 days before 9 months before you can bring your patient into clinical trial. So please think about that as you're moving forward. Do what you need to do. This is not meant to be a public service announcement that way, but keep that in mind. So what about eculizumab? I know this is a little bit of a busy slide, so I'm just going to share with you. If you're in the yellow on this slide, you are a complete responder. Blue is a partial responder, and red is no response. This group is 26 patients. I've only presented you the adult patients here. The first 13 were children. 6 of the 26 went into remission with eculizumab. 1 was a partial remission. By the way, it did not make a difference whether, or was not predicted by the soluble membrane attack complex, as we have seen in our previous publications that it might be. The point is that There's enough patients that do not respond to eculizumab, so keep that in the back of your mind when you're deciding to use it. It's like mycophenolate. Some will respond and some will not. And then again, I couldn't resist bringing up the Glossen group again. They had 33% of their patients that actually went into remission with eculizumab. To be fair to mycophenolate or terminal complement blockade, please remember that across the world, we're using these things differently. So really, we may be comparing that remission didn't happen, but it might have been not the proper dosing regimen or. So keep that in mind, because again, we don't have the data we need to make a full decision on whether these things are going to be successful or not. So that the new KDIGO, the 2021 KDIGO said, while eculizumab can be tried, please consider the clinical trial option. And so what about the current therapeutics? And some of this is supposition. It is our best guess about how clinical therapeutics might be working or why they might not be working. So let's think first about steroids and mycophenolate. The first might be is they block proliferation. They may also somehow inhibit the B cell or the T helper cell when it comes to making those antibodies of concern. So that might be how you're getting some effect in this disease. How about terminal complement blockade? Well, now you're blocking the terminal pathway. You may not be blocking the C3A, an aflatoxin effect now. You're blocking the terminal pathway. So that actually may bring some, take the Glossen group, for example. That may be what needed to be fixed in that 33% of the Glossen group. What you're not doing is what has already been mentioned to you by Dr. Kavanaugh is that this activity at the convertase level or at the amplification loop is not being affected by any of these agents, presumably. So that's why someone might think to move forward to these targeted agents. So what about targeting? I'm really only going to present two very quick slides, and they actually are abstracts because, again, we have very little publication data on this. One is on an abstract that was brought to ISN, and this is on, I cannot pronounce this, it's the C3 inhibitor. It was a phase 2, and what you'll see in this study is that there was a 65% reduction in 24-hour urine protein for this group. Stabilization of the albumin. There was an improvement in the C3, and there was stabilization, possibly even improvement in the serum creatinine. How about the complement B inhibitor? Also, 49% reduction in urine protein, GFR stabilization, and then the same story pretty much. You have some degree of improvement in the C3. So the point is I'm bringing the older abstracts to you. There are other abstracts coming to all of I've seen many of them coming to our congresses this year. So probably in your meeting right now, you'll see them. I know they'll be coming to, for instance, the American Society of Nephrology in the coming year. Keep that in mind to keep looking for these abstracts because they're going to tell us what's going on in the targeted therapeutics world, and they should be giving you the information you need to be considering clinical trials or what is coming next. I wanted to present one patient to you because this is the concept here. This happens to be one of those panels that you can get for your complement workup, if you will. This happens to be ours. That won't surprise you, but you can see that it's broken down into pathways and then the autoantibodies and then the breakdown products or complement levels. I just want to present this one patient. This patient's C3 is completely undetectable. It's been undetectable for the 5 years that I've known him. I start an agent on him. In this particular case, I wanted to start one of the agents in the amplification area or near those enzymes that Dr. Kavanaugh presented to you. I happen to have started a factor B inhibitor in this patient. So then I watched him for a while, and you can see what's happening to his C3. So that by the fourth measure that I get for him, in fact, I get a normalization of the C3 in this particular individual. Here's the problem. We don't know as a collective group of clinicians what this means clinically. So this is what our clinical trials owe us moving forward. Is it important that we can normalize the C3? Does it give us what we need on a biopsy? Does that give us what we need in terms of GFR and proteinuria, et cetera? So that's the direction that this field is moving, is this idea of targeting Targeting the kidney, yes, but then we have to figure out what do we consider as success. And so this is what I've listed as our future directions. We have to improve our understanding of the natural history of the disease, particularly who can do with just supportive care versus who needs their a care escalation, I would say, but also this concept of do improved biomarkers equal improved renal survival? We don't know yet, and we need to know that. We need to identify prognostic markers. You've heard some about the biopsies. By the time you get the chronic biopsy that gives you the prognosis the disease is progressing, that's too late for us. We need earlier biomarkers to be able to impact and move forward. We also need to identify the therapeutics. We need to be able to enroll the people in the trials. We need to figure out what success looks like. Is it normalization of a biomarker, or is it improvement of urine protein, et cetera? We need to know these pieces. And then finally, in general, and as you're going to get throughout the rest of this series, we need to understand the role of complement in glomerular disease in general so that we can really position these future therapeutics, these novel therapeutics for the future of our glomerular diseases. And I just say very quickly, I have a wonderful work family in the Moral Laboratory, plus my division is absolutely fantastic, supporting me along the way. So I thank them, and I thank you as an audience for listening to us.
Thank you very much, Dr. Kavanaugh and Dr. Nestor, for an excellent presentation, lots of new information and lots of food for thought going forward with this interesting group of disorders. With over 375 participants, we have a lot of questions, and we now have about 10 minutes or more for answers from the speakers. And I've been monitoring the question and answer box, and I'm going to try to pick out as best I can the questions that popped up during the discussion. Let's start with one for David. The question is a pronase digested paraffin immunofluorescence always indicated if a kidney biopsy studied by frozen immunofluorescence shows C3 dominance and little IgG deposition?
So yeah, I think some of this depends on the clinical kind of condition. You know, if you have an over 50-year-old and you're seeing C3G and there's not much there other than C3, you're going to want to do that because you have a high index of suspicion for some sort of monoclonal gammopathy driving this. So we do tend to do it in the older patients. We probably go over 40, and certainly we will do serum free light chains in everybody. And it's those kind of things where it will drive you down a pathway, because as Carla nicely presented, if you find a monoclonal gammopathy that's driving this, you do much better if you treat that than trying to treat it as a C3G.
Thanks, David. Let's go to Carla. We had a couple of questions about ANCA vasculitis, in which the biopsy shows prominent C3 deposition and a pauci-immune pattern. Should such a patient be treated with a complement inhibition agent, for example, avacopan, or should the patient receive standard treatment for C3GN?
Yeah, so the easiest answer is they should be receiving standard treatment right now, of course, because we need more data. But it's an interesting concept, because what's not clear to me in that setting is whether there really is complement activation as a second primary driver of disease, or if complement presence there is just because, you know, I don't know if you all know, you have 5 grams of C3 in your body. It doesn't take a lot of complement activity, whether it's being driven by an autoantibody or an ANCA. If there is any reason to have excess complement activity, it doesn't surprise me that you might get some C3 deposition on a biopsy. Having said that, I think that there are coming some good trial data or some good opportunities to think about using a C5a receptor blocker in the ANCA setting. Now, to be clear, a C5a receptor blocker won't necessarily alter the C3 deposition on the biopsy. It's the same concept that eculizumab in C3G will not alter the consumption of C3. It's working too far down the pathway. So I waffled a little bit on that for you, but the point is that I think you have to use standard of care right now. If standard of care comes to using something like a Vacapen because that's better for the ANCA portion of this, that's different. Whether someday we are treating ANCA patients with, I was trained in the Ron Falk, in the Chapel Hill, that's where my training was. So I know a lot about ANCA. If we use Rituxan or cyclophosphamide and a complement inhibitor one day, I would not be surprised at all, because it might be a better approach to these antibody-driven diseases.
Thanks, Carla. David, we had an interesting question. I suppose it might come up more frequently as we measure C3 and C4 as a screening test. And that is a patient with a very low C3 level in the blood, but a normal or bland urine and normal renal function. Should a kidney biopsy be done in such a patient? Or should a genetic test, or should functional assays be done?
Well, no, I wouldn't biopsy a person with just an isolated C3, because whatever you find, you're not going to do anything with that. However, the real thing you need to think about here is if they have no C3, they are going to be predisposed to meningococcal sepsis. So you want to do some functional analysis of the complement system, AH50, CH50, something like that. And what we would do in this situation is we would vaccinate them and give them antibiotics, because we would treat them as a complement deficient individual. Now, you might want to work at why they're complement deficient. You might want to screen them. There are lots of things you can do, but I wouldn't biopsy them.
Okay. Carla, a common problem is patients with a throat infection in the relatively recent past who develop AKI and have a biopsy showing a lesion that looks just like C3GN. Dominant C3, minimal IgG deposits. Should that patient be treated as a patient with C3GN, or a patient with an immune complex type post-infectious GN?
Yeah, so you are correct, and maybe I don't understand all the pieces, but my understanding is about 30% of true post-infectious GNs can be C3 dominant, or maybe even C3 isolated. So it is an accepted phenomenon that a true post-infections, i.e. transient complement activation patient, may have a C3G looking biopsy. So that's one piece. But then the second piece is, if I have a patient that has a sore throat and 2 weeks later you do the biopsy because of an AKI, you find a C3G biopsy, by consensus, you can't call that patient C3G because it's too close to the infection. Now, you can have your flags up and you can be thinking, I'm worried about this. There's no reason for this patient to have AKI. And so, yes, maybe you just follow them closely and make sure that the AKI recovers. Or maybe you do jump in and try, some steroids or something to actually calm down the lesion. But that's the type of patient that if they are not better by 12 months, 12 weeks in 1 day, that I am worried about whether they actually do have C3G. But I recognize what you're pointing out. It's that sort of limbo period where we're not sure exactly what the patient has. And it can be difficult. So your glomerulonephritis gut, if you will, has to tell you what to do in that setting. If it's crescentic, of course, you're going to launch on an RPGN sort of treatment pathway. But if it's not crescentic, you perhaps have some room.
David, a question came up about whether C3GN and atypical hemolytic uremic syndrome can exist simultaneously in the same patient at the same time.
Well, I kind of presented the dogma that factor H N-terminal mutations will cause C3G and C-terminal ones will cause aHUS. There are clearly cases where you can get switching from C3G to aHUS. They're relatively rare. Do they exist at the same time? Difficult to know because they'll be biopsied at different times, but you can certainly see a patient with C3G that subsequently presents with a TMA type phenotype, but they're relatively rare in my experience, certainly.
Carla, a question has arrived about what is the role of genetic studies in a patient who has C3GN that has progressed to end-stage renal disease and is a candidate for transplantation?
Yeah, that's an excellent question. And that for me is the time when genetic studies are the most important from my standpoint. I appreciate the genetics whenever I see a C3G patient because it counts for a quarter of the patients. But from my standpoint, the time immediately before transplant becomes very important, because especially perhaps in pediatrics, potentially more than adults, because we often use related donors. And we would not be interested in taking necessarily, we've done it once in my career, where we would take a related donor for a patient who has a clearly pathogenic C3 or factor H gene abnormality. So we would not be interested in taking that related donor. So that for me is a very important time to actually consider doing the genetics. And then, of course, you do the patient, and then you would screen the donor pool for just that familial mutation, potential familial mutation. I know that practice can be very different across centers, but that is the approach that we would take here.
This is a question for both David and Carla. It came up several times. Resource-poor settings in the world have limited access to complement functional assays or genetic studies. What is the essential approach to a patient with C3GN when you have very limited access to these studies that are required for complete evaluation? Carla, do you want to take it first, or David?
David, you want?
Why don't you take it first, David?
Well, I mean, it all depends. I mean, clearly the main test you need is a biopsy, which most people will have. And I think after that, everything is an add-on. A C3, you might want C4. I mean, those would be I think you can probably manage most things with a C3, a C4, and a renal biopsy. I mean, it would be nice to know what the underlying driver of disease was, but at the moment, Carla might disagree with me here, it doesn't really matter what we find is driving this. It doesn't alter our management. And as Carla said, we're slightly different in that we don't necessarily recommend screening before a C3G transplant, because there hasn't been a case of our donor actually developing C3G after donating it, and so there are differences. But to answer the question, I think you don't need genetics, you don't need fancy complement tests to manage it. Basically, you need a biopsy, and you need I would say a C3 and a C4. Now, I would argue that as we know more and we get more complement inhibitors, that's when these fancy tests will come into their own. But at the moment, and Carla, you're welcome to disagree here, I don't think they actually alter our practice, but they will likely do in years to come.
Carla?
Yes, exactly. I agree with you, David. And I might get kicked out of my office by saying this stuff, but it's exactly correct in that I think that we need to understand the drivers of disease, frankly, if we're going to understand disease. But if you're really research strapped, knowing whether it's driven by a nephritic factor or knowing whether it's driven by a C3 gene mutation does not change your on-the-ground behavior for this patient. And I would say, hopefully I said that even the KDIGO recognized that it was a little bit of forward thinking about this idea of even working patients up so extensively. I will, though, offer now my opinion about this. I think that the breakdown products are going to be probably the more important piece, because if you've got excess breakdown products, not BA, because BA is related to degree of kidney dysfunction. But let's say you've got excess BB or excess C3C or things like this, those may come into play. I think you're going to see, I think, some pretty fun abstracts in the congresses this year about things like this. I think that they may end up being the most helpful. But like David said, you've got to have the right biopsy. You've got to have some evidence of complement dysregulation, because again, you don't want to drag in FSGS patients here. You want true C3G patients that you're dealing with. So the biopsy, probably the proteinuria, because that's what we're treating against right now, and then some evidence of complement dysregulation. And you know, nephritic factors and genes don't necessarily help you with that.
While you're talking, Carla, a question came up about the role of sort of non-traditional therapies like rituximab, cyclosporin, and avacopan in the treatment of C3G, treatments other than MMF and steroids. Any comments?
Yeah, again, no trial data that we can really depend on. I have not seen the avacopan final results, so I don't know exactly what that will look like. But I will say that just based on the fact that blocking C5a does not block C5b through 9 or the alternative pathway amplification loop, I can say that I would not be surprised that patients that are not as inflamed but very active yet on that side might not have the effect that you would want. Rituximab makes wonderful sense in those that are driven by nephritic factors, but it's the publications, which there may be lots of publication bias, the publications do not uniformly support the success of trying to knock that B cell down and then therefore getting rid of the nephritic factors. And then you brought up one more, avacopan, rituximab, and what was the other one?
Right. Avacopan, cyclosporin.
Oh, cyclosporin. I actually do use, and David, I don't know, as a clinician now, not as a scientist, but if I have a patient who's on eculizumab or on mycophenolate, and they've got lots of success, but they still have nephrotic range proteinuria, intermittent nephrotic syndrome episodes, I will add on a CNI. And I will use it actually to help get the urine protein down low enough that they stop getting admitted to the hospital with their nephrotic syndrome episodes. That is purely, you know, anecdotal information, but it is worked frequently in my practice to limit that particular piece of the disease. I don't think it's doing, I think it's probably a podocyte directed therapeutic. It's not a complement directed therapeutic at all. So keep that in mind.
The inevitable question about SGLT2 inhibitors has come up. Almost always I'm asked this question: do you currently use or prescribe SGLT2 inhibitors for patients with C3G and progressive CKD? Either David or Carla or both. David?
They're likely to come in, yes. I mean, we haven't necessarily started doing it yet due to, I mean, they're just coming in the UK, so they will undoubtedly be used, I would have thought.
Yeah, I think so. I think that I don't use them a lot yet, but I think they will come into play. The only caveat I would offer is that they belong in the supportive cares box. You know, they're not a targeted therapeutic with respect to complement anyway. And I don't think that most of us believe that only fixing protein will fix this set of diseases. So, but I you know, again, we need data to support. But yeah, I do think they'll come into play, and I'm not against using them, since, you know, more than 50% of my practice is pediatric. That's probably perhaps why I don't use them as much as some others do, but they will come into play as supportive cares. I'm sure they will.
We're running out of time, and I'm only going to try one more question because and there are lots of others. I think we've got almost 30 questions from the question and answer. We'll try to answer some of these in typewritten form rather than oral form after the session is over. But I do want to ask David, retinal changes, drusen, are they equally likely to occur in patients with dense deposit disease, C3GN, and the complement factor related 5 protein, or is there some difference in those different entities.
All right, Carla may help me out here. I'm not particularly aware of it being a major problem with CFHR5 nephropathy. I mean, it tends to be, I mean, the C3 nephritic factors are clearly the ones that they were described in and the commonest. I would say we had, I mean, with the increasing in genetic screening, the increased awareness of the role of factor H, C3, and factor I in AMD, we are routinely screening patients. I would say it's pretty rare to find stuff. And then the ones we've found, it's pretty much been universal in C3 nephritic factor. From the point of view of in the very old groups, we have found factor H mutations. Whether they're whether it was driving or they just developed AMD, I know what I think, but I don't have evidence to back that up.
Yeah, I think we're missing a good bit of the natural history to understand exactly. I think my impression is it's also mostly in the DDDs, but I would absolutely be screening all patients that you think might have complement-driven disease.
That means an ophthalmologist doing a good retinal exam, right?
Yeah.
Well, listen, we're running out of time. The questions and the answers have been spectacular. The session has been extremely well organized and illuminating. We have a lot of work to do. This is an exciting period in the history of this group of disorders because the pipeline in the future is very impressive. We hope that in the next few years we'll have even more complement inhibition agents that have shown efficacy and safety in these diseases. Maybe we should repeat this webinar in a couple of years. I suspect it will be greatly different than the one we had today. But I want to extend sincere appreciation on behalf of the ISN and KDIGO to Carla Nestor and David Cavanaugh for giving us a real sharp and useful insight into a complex and often difficult to understand a group of disorders. And I appreciate the work that they put in to develop these, the slide set and all of the answers to the questions. And particularly, I want to express my gratitude, again, on behalf of the sponsors for the many participants who joined us today. I think we'll sign off now with thanks and good luck.
Thank you.
Thank you.